just hope that you are enjoying the session so far. We're just winding up with the COVID vaccine session on the other side where Professor Odami is joining us. So we are excited for you to witness history for us as we have this first conference, the first ever sickle cell conference in Australia. And we have Dr. Kongolo is back now and Dr. Mwikisa, and I'll hand over to Dr. Kongolo if you are here. Mr. Mwikisa, once you have the audio, you can take over as the host. Thank you so much.
Good afternoon, ladies and gentlemen. My name is Mwikisa Nabita. I have a privilege of moderating this session, and we are privileged to have Dr. Kongolo Kalumba with us today. Dr. Kalumba is a consultant pediatrician and pediatric hematologist. We are privileged to have you, doctor. Please go ahead.
Yeah, thank you very much. I would like first to thank all the organizer for this opportunity for me to present today on the impact of COVID-19 on sickle cell disease. I think it's a very interesting topic because the two conditions can have some sort of interlink and can have a negative impact to each other. Sorry, next slide. So we all know that COVID has been a disaster and has put basically the whole world on its knees. And from the time we started having this problem in December 2019, it's created significant health problems on a community level, individual level, and also significant economic problem, complete shutdown of activities until early this year when they start seeing light at the end of the tunnel when the vaccine has been approved and the rollout of the vaccine has commenced. So why do you want to talk about this? Because first we need to understand the impact of COVID on sickle cell disease and vice versa. And then we review some data which are available at the moment. So looking at the incidence of complication on a patient with sickle cell disease during COVID-19 infection. And also we start to discuss the how do you go about to prevent those complications. We touch base with the management in general. So why is it important to understand? Because sickle cell disease is a significant burden in public health worldwide, even though some countries are affected more than others, such as Africa, Sub-Saharan Africa, and India. But we recognize that about 8 to 12 million people around the world have sickle cell disease, and so other many of 300,000 who have sickle cell trait. And also it's possible that many people with sickle cell trait are still undiagnosed. And sickle cell disease can affect many organs in general. So understanding this, we should have the policymakers to set up, to roll out adequate and excellent policies to deal with these issues, and also to prioritize vaccination of COVID, particularly on sickle cell patients, because they are vulnerable people. So far we have so many data, but there are other things which we don't know yet, how COVID vaccine will interfere, will affect sickle cell disease and vice versa. And secondly, there's also significant similarity of symptoms between the two conditions. It can be quite difficult for the patient to know what is going on. Even some doctors who are not used, who don't see sickle patient on a regular basis. Certainly, there's potential negative interaction, as we mentioned before. And also, these two conditions may have some common mechanism which may affect the patient. Here, I want to emphasize on vascular dysfunction, which we see in both COVID and the sickle cell disease. Sorry. So, in terms of how can COVID affect the sickle cell disease, we know that COVID disease is mainly the way it actually reverse, will get in your lung, and then it will dysregulate, downregulate your ACE2 receptors, and leading to significant inflammation in the lung and some other organs. And as a result, this will lead to significant hypoxia when in severe forms, and also significant inflammation on the chest, pneumonia, with release of a lot of cytokine. And we also know that hypoxia is the main factor for sickle cell disease to have complications such as vaso-occlusive crisis, chest pain, and acute chest syndrome, and other complications. So certainly hypoxia can be a trigger for a complication for sickle cell. So also when someone has COVID, may not be able to take enough fluid intake, which can lead to dehydration, can also affect the sickle cell patient. We also know that COVID, it has a significant inflammatory process of cytokine storm, which can affect most of the organs and the vessels. And this can also affect sickle cell disease. The last thing is the coagulopathy. COVID has significant role. Most significant patient with severe COVID disease may have a high chance of having clot, 100 times more than the general population. So we can see these familiarities. So acute chest syndrome can be very difficult to differentiate from someone who has severe disease, COVID-19 disease, because of the chest manifestation, the chest pain. And also the person with COVID can also have clot, which can be in the brain, can be in the chest, in abdomen, can give pain. So there's quite significant similarity on both sides, and which can be very difficult to differentiate if someone is not dealing with this condition on regular basis. So we look at this US sickle cell disease COVID-19 registry. Here, 178 sickle cell patients were reported from March 20 to May 21. An average age of this cohort was 28.6 years. And the majority has at least one or more sickle cell disease related complications in the past. So here 69% were admitted in the hospital during COVID-19 illness, and about 11% were admitted in the ICU, and 13%, 7%, so 13 patients died. So some other data from the registry from the US, from Wisconsin. So from January, September 2020, again here we have 312 with COVID-19 and sickle cell disease. And there was 449 patients with COVID-19 and the sickle cell threat. So among these patients, we can see that there was increased risk of hospitalization with relative risk of 2.0, and also development of pneumonia with relative risk of 2.4. So, and however, the case fatality rates were not significantly different between the two groups. So those with sickle cell disease with COVID versus those without, with COVID without sickle cell disease. So this again just highlights the death. We can see that the most significant differences is the admission rate at 14 days, which is quite significantly among the group with sickle cell disease. And also we can see the other differences is a pain. So among patients with COVID and sickle cell disease, pain is the most common symptom for admission and comorbidity. And then you can see also pneumonia or acute chest syndrome, which come on the third place with about quarter of a percentage. So the whole this data is analyzed also from US, analyze the role of comorbidity, again, as I said. So about in this cohort, so 750 cases were analyzed, and 48.5% were children with a median age of 11 years, and 51% were adults with a median age of 31. So most common comorbidity here was prior acute pen visit, which 55% of children, and up to 78.5% of adults. So acute chest syndrome also almost 30% of cases in both adults and children. And the pen was also seen as a presenting symptom in 35% of children, 67% of adults, followed by acute chest syndrome. So use of hydroxyurea lowered the risk of presenting with pen, but overall did not make significant difference in outcome. This retrospective cohort of more than 12 million adults and children, which is the British cohort, and more as 30% of these patients were less than 18 years of age, and 5,000 with sickle cell disease and 25,000 of sickle cell trait. And the risk of COVID admission and death was significantly higher on a patient of sickle cell disease compared to the general population, with a hazard ratio of 4.1 and 2.6 respectively for sickle cell disease patient. And also as the hazard ratio 1.4 and 1.5 respectively for sickle cell trait. There is a suggestion that people with sickle cell trait, when they have significant hypoxia, may also have sickle cell disease related complication during COVID-19 infection. However, this hasn't been, there's no strong evidence at the moment with regard to that. So this point up to say that we need to understand more, particularly patients who have sickle cell trait, because they also may be at risk of a severe COVID disease. This is again the registry from the US. This is from August 18 this year. So about 849 have been recorded. And we can see here, this is sex distribution between female, maybe more female than male. And again, to have a similar thing, we can see that most of the patients on this group are already on the hydroxyurea, about 50% of them, but that did not make any difference in terms of outcome during COVID infection disease. In terms of treatment, so most 20% receive azithromycin. It was unclear where they got whether from the hospital, from the GP, and about just under 10 had corticosteroid, and 21% were paralyzed. So the symptoms so similar again here, figures pain, but almost half, and following by chest infection, about 22% of cases. So disease severity, as for COVID, most of the cases were mild, but then you can have, so there was a moderate up to 12% and also severe, which was a quite small percentage of about 1% critical. And the mortality was about 17 among that group, age group. So that again, just showing a cohort from US and the comorbidity. What is that to highlight here? So asthma has been a strong comorbidity among patients with sickle cell disease and COVID, both for adults and for children. So what we do, so I think is important that most patients with sickle cell disease, and also try to draw attention to those with sickle cell trait, to mention to their doctor when they got COVID infection and they have this condition, because it's important. Of course, you have to take extra precaution. You have to observe all the measures with preventive measures. We know against social distanciation, hand hygiene, wearing masks when it's appropriate, and staying strong when you are sick to protect your community. Always still apply. We need to do that. Don't be isolated. Connect yourself to, because COVID-19 can have a significant impact on mental health, and particularly with lockdown we're experiencing. It's important to remain connected to your family, to your friend. But most importantly, priority is that now we have effective and safe vaccine. You need to take the vaccine. That is a vaccine save lives. And vaccine has been the most public health victory in the human history. So this is important. There were a lot of concern about some side effects. We just have to remember that we haven't experienced this kind of vaccination in large scale. And we anticipate that there will be side effects. Anticipate there will be some death. But overall, they're very, very minimal compared. If you look at the balance between the benefit of the vaccine and the risk by itself, so the risk is serious but rare. So it is important that people get vaccinated, which data can demonstrate that. So then you can see that your vaccine, if you have a severe COVID disease, you've got 10 times more risk of having a clot, blood clot, which most people now worry about, compared to if you are given AstraZeneca vaccine or Johnson & Johnson, which are both adenovirus bacterial vaccine. So it's important that we take that, because if you don't, if you get the disease, your risk of clot has been higher, 10 times higher than if you are vaccinated. So we now understand also, someone will ask, so someone with sickle cell, should we take vaccine? Yes, the answer is yes. There's no reason for this at this stage to say that they may not be able to mount the immune response they should even if they take the vaccine. That is comparable with flu vaccine. However, we don't know how long that will last. It's the same as for the general population. We're not sure at the moment how long it will last. This is just a mechanism of reclotting. I don't know how to get in this, but we know that clot is not everyone who develop clot. The mechanism now is understood. It's a hit which is heparin-induced thrombocytopenia type, where there's antibodies against which look like anti-heparin antibodies. We were going to stick to one part of platelet, which we call a platelet factor 4. And then from there, that small particle, factor 4, become immunogenic and activated. And then it activates platelet agglutination and with clot formation and drop of a platelet. But that should not be the reason why we shouldn't stop, should avoid the vaccine. What is important here, most of African descent, or in the US and in Europe, the vaccine hesitancy has been very high. Unfortunately, that's also where we found the higher incidence of sickle cell disease. So it is important to recognize that if we don't take the vaccine, it's certainly going to affect that number of people which we need to protect. So be cautious. Every country is trying to follow the side effect. If there's any significant side effect, you have to report it to the authorities. There are data which are being followed and being analyzed all the time. So don't be scared of the vaccine. It's safe and effective. Just remember that also that continue to keep to observe your other preventive measure, as I've mentioned before. So this is just to highlight that if you don't take the vaccine, you actually end up having severe COVID disease. Your risk of clot is higher. So it is a priority. So in summary, this data suggests that the risk of admission in the hospital is increased on a patient of sickle cell disease and COVID-19, and also that the risk of acute chest syndrome of pneumonia is higher as well. Perhaps the mortality rate is higher. You see the data, there's a bit conflicting, why some suggest that there's no difference. There's a small study from France experience where they found that there was no significant difference on mortality, but there was only 86 patients, and that's study was small and underpowered. So it's possible also that the sickle cell threat can also be at risk of complication of where they develop COVID-19 infection. Vaccine are safe. I can't say that I heard that enough and effective. It is important. That's a way out at the moment. So the sickle cell disease patients should be put among the vulnerable population and given priority for COVID vaccine. And obviously more study are needed to understand more interaction between these two diseases. Thank you very much.
Thank you very much, Doctor. I would ask a few questions, if you'd allow us.
Yes.
And if I can get some more questions from the audience, I'll appreciate. The first question I have is, should children with sickle cell be vaccinated as well?
Yes, the answer is, so at the moment, most countries vaccinate from 12 years, so we've gone down to 12 years. So just for most of medications, if you look at the history of medication or vaccine, normally the experimentation we start sometimes with the animal model, then they go to human, start with adults first, because people are still scared to put anything in children because they're finally developing, most of their part developing. So often it will take years and years before it reaches children. But where we are here now, that the side effect we have seen, even in children, so we're down to 16 now, down to 12, has a significant number, which of concern. Obviously, we don't know what will happen in terms of long-term effect. But if you want to get out of this, we need to get the vaccine. Children tend to do mild form of disease, we all agree that, but they can also transmit. So if we want to protect, we need to reach that level where the community is vaccinated is 75, 80% or more. So we need to vaccinate also the children. There's no, at the moment, a indication that sickle cell disease children should not be vaccinated. Obviously, if they don't, because in some cohort, some variant we're seeing now, even some children under 20, under 10, they've been affected as well.
The second question I've got from the audience is, which vaccine would be suitable for young children? I would put it exactly with sickle cell. Have we differentiated them so far? I understand they're being developed now. So have we identified which one will be safer for young children with sickle cell and which one will not be safer?
Yes. No, I don't think we have identified that. But in summary, there's, in most of Western countries, there's 4 types of vaccine being used. So, I mean, 2 types, but 4 vaccines. So we have mRNA vaccine, which is Pfizer and Moderna. And then we will have adenovirus DNA vector vaccine, which is AstraZeneca and Johnson & Johnson. So in terms of, there's a number of, in terms of the 2 vaccines, AstraZeneca and Johnson & Johnson, the main issue has been clot-related thrombocytopenia, which is a immune-mediated system. So we can't predict who's going to react to that. So there are people who are going to make antibodies, which is autoimmune condition. So they make antibodies against their own platelets because they've been exposed to something. We don't know exactly what that thing is, because some people have been exposed to heparin, treated with heparin in the past, then they develop what's clot, that syndrome called HIT, so heparin-induced thrombocytopenia. So, but in this case, most of the patients who develop clot hasn't been exposed to heparin. But we think that there's another substance in those vaccines, AstraZeneca and Johnson & Johnson, could play a role. So mostly it should be a negative substance, because the platelet factor 4 is positively charged. So we believe that it's negatively charged. It could be perhaps a DNA, which is in the AstraZeneca and Johnson & Johnson vaccine. We don't know yet, or some other ingredient. But overall, we can't predict. It's a immune response. It's like someone give you today, they gave you a medication, or you develop an infection, and then it ends up developing antibodies against your own part of the body. So this is a mechanism you cannot predict who's going to do that. I don't see any contraindication, but with mRNA vaccine, we haven't seen that was condition we call a vaccine-induced immune thrombotic thrombocytopenia. So that hasn't been really seen in mRNA vaccine, meaning Pfizer and Moderna. But there have been also some other side effects like myocarditis and pericarditis, and with Pfizer or Moderna. But again, there's no way you can predict who's going to develop those complications. So in short, there's no clear answer to that, but who is the best vaccine? If you had the vaccine covered differently, Pfizer have up to 95%, AstraZeneca around 70%, but both protect against severe form of the disease. So moderate to severe form, and most particularly, importantly, against death and hospital admission. So that's what is important. You can still do the disease, control the disease, but you don't develop severe form in a majority of cases. However, so both vaccines, if you got most young people prefer to take Pfizer because most of the clot initially, when it was reported, it was only among young patient of 40 or below 50. And we don't know why, perhaps, and that's more female, perhaps it was because they were vaccinating young people who were the health worker, and most of the health workers were female. So then as data comes in, we also saw, we were seeing cases among, in the UK and elsewhere, among 70 years, 6 years. So the bottom line, so Pfizer at the moment is what to prefer for young people because of what's initial data. So Pfizer or Moderna, which is a mRNA vaccine. But where there's no Pfizer or Moderna, I think it's important that we get a vaccine such as AstraZeneca or Johnson & Johnson. It's particularly some other countries, particularly where it can be difficulties to obtain Pfizer or Moderna, and even to with difficulties of conservation and documentation can be difficult with those vaccines. I'm not sure whether I've answered your question. The answer is there's nothing to say sickle cell should have this vaccine. There's no reason why I shouldn't have a vaccine when it's available, but the preference would be Pfizer or Moderna in the young children, in young population at the moment.
Okay, thank you very much. Then we would say the effects of vaccine on sickle cell patients has not yet been established as much, isn't it?
Yeah, no, hasn't been established as much because we're still collecting data. So, but from the indication so far, I'm not sure how many. US has about 100,000 people living with sickle cell. So some other country, France is probably having the highest number of sickle cell, about 26,000. But the biggest number of sickle cell, they are all like in Africa, sub-Saharan Africa and Indian. But there's no indication at the moment to say there's a contraindication to the vaccine for them. There's no indication to say they may not be able to mount a response, immune response, adequate response at the moment, but this data is underway and we know more as we progress.
Okay, thank you so much. I haven't gotten any other question.
Yeah.
Thank you so much, Dr. Kalumba, for the wonderful information. So it seems like we're at a stage where we are all learning about it, isn't it? We are learning. We must keep learning about it. Yes.
Absolutely. So we are learning about COVID, and I think we are all learning, and we'll continue to learn because even the vaccine, how long that will last, are we going to require a third dose, a boost, or another dose, or how many doses? We don't know. Time will tell. But at the moment, it seems like after 6 months, we're still holding on. There's a concern that the efficacy of Pfizer has dropped after that, but it's still adequate to prevent against severe form of disease and death, which is a good thing. But to get the community out of this, because this is unprecedented, if we get a community, we need to get this 75–80% vaccinated. Otherwise, we're not going to function. It's a complete lockdown again and again and again. So we need to understand, yes, there will be surprises possible, but there's a pharmacovigilance in most countries, and data are being collected, and people are encouraged to report any side effect or any things which happen after vaccination if you don't feel right, to report to the authorities so that it can be analyzed and see what they understand what's going on.
Right. Thank you so much, Dr. Kalumba. We really appreciate your time and your information. We'll certainly put it to good use. Thank you so much. We'll keep watching and learning as well.